Okay, it's good. So this looks good. So good evening, OPN, and also Gentle Bear for broadcasting this on OWNN. And I hope we have local viewers on tonight because we're really fortunate to have Dr. Steve North on with us. And let me click a few buttons and bring Dr. Steve on in video. Ta-da! There's Dr. Steve North. Why don't you just say hi to the folks and let's make sure they can hear you, Steve.
Hi, how are you folks tonight?
Yeah.
Wherever you... Yeah.
Okay, great. That sounds good. So we have good AV, so we'll go ahead and launch into it. Thank you so much for being here with us tonight, Steve. I really appreciate it. Dr. Steve is coming to us from the hospital, so if he has to jump up and leave, that'll make sense. But,
I'm not on call. I'm here for this. Yeah.
Okay. So yeah, in our little area here, it's a search for good internet, and that's what happens. So, Dr. Steve North is a doctor here in Spruce Pine, North Carolina, and he serves Mitchell and Yancey counties, which are adjacent counties here. He practices family and adolescent medicine and is currently the president and medical director of the Center for Rural Health Innovation. And you guys have heard me talk about this project for about 6 months now, so I'm really excited that we can get Dr. North on. So welcome, Steve. Thank you for being here tonight.
Absolutely, Mark. Thanks for having me. I have not done one of these before, so this should be fun.
Yeah, we'll try to make it a good experience. So why don't you give a better introduction of yourself, you know, your background, your interests in education,
okay,
and your life geography.
All right. So I grew up in northern Wisconsin in a county that had more dairy cows than people, right in the middle of the state. And went to Wisconsin, University of Wisconsin-Madison for undergrad. When I graduated from Wisconsin, I wasn't sure what I wanted to do. Lots of people had said all along, well, your dad's a great family doc, you should go and do the same thing. And I wasn't convinced that I was, applying to medical schools for the right reasons. And this great program called Teach for America came along. And I was selected and got to be one of the first Teach for America Corps members out in eastern North Carolina. I taught in Edgecombe County, which for folks sort of thinking about maps, is about halfway in between Raleigh and the beach, just east of I-95. And one of the things that I saw there was that my students really had poor access to health care. And I was able to see how that impacted their ability to learn. Stuff like having stepped on an exposed nail in the floor of the sharecropper shack that Tim lived in, and how that he wasn't able to learn. Mom and Dad had one car, both working 2 jobs, and they just couldn't get him to the doctor. At the same time, I read a great book by Joy Dreyfus, Dreyfoos, called Full Service Schools. And this book looked at this sort of new concept in the early to mid-90s, so 93 to 95, called school-based health centers. And that was the idea that you could provide for a kid's social and emotional needs at their school, and bring a full-service clinic into the school and take care of everything. That really got me thinking about my students, their lack of access to health care, and how, for them, the school bus was their main source of transportation. So I ended up in medical school at Chapel Hill, and then where I met my wife, Jen Larson, and then from there we went to Rochester, New York, where I did a family practice residency, and Jen did a residency in internal medicine. During my first year at my residency program, there was a school right across the street from the hospital. And one day after I was done rounding, I went across the street to vote. And all of a sudden, I found myself in the principal's office with one of the secretaries who was having a sugar reaction. And she actually probably had a lack of sugar, but had taken her insulin in the morning for her diabetes and just wasn't coming around. So helped them out, and all of a sudden had this great into the school, and began to bring residents there and talk about schools and how doctors and schools interact. Too often, a parent will come in and I'll ask the great question of, well, how's Johnny doing at school? And they'll say, fine. And unless you ask that follow-up question of, well, what does fine mean at your house? It could mean that Johnny hasn't been suspended in a week, or it could mean that he only got one wrong on the spelling test, and that the family expectation for grade is none wrong, ever. So that was a great experience for me, and built a curriculum with the residents there around spending time in classrooms and seeing kids in sort of their natural environment. I ended up doing a fellowship, a 2-year fellowship in adolescent medicine, so additional training and working with teenagers. People often say that there's this whole "Doctor, heal thyself" motto or mantra, and most orthopedic surgeons are ex-jocks who have broken a couple of bones along the way. And well, what does it say about my adolescence that I was drawn to adolescent health care? And unlike most of the folks in adolescent medicine, I really didn't want to stay in academic medicine and research little minutia questions about condom use among Zambian boys between the ages of 14 and 16 who smoke less than 2 cigarettes per day, and have always been drawn to rural communities. And Jen grew up in the mountains of western North Carolina. After looking around, we decided to come back to Jen's hometown and to what's now our hometown here in Spruce Pine. I was hired by the Bakersfield Clinic, which is now a federally qualified health center, but a very community-driven practice in the middle of our county. Our county only has about 16,000 people, and so the town I practice in has 300 people in it, and we're the biggest practice in the county, and have been around for almost 40 years, having originally been founded with Robert Wood Johnson money, and an emphasis on rural health programs. So through my own interest and some support from a state organization, I was able to get this idea of providing school-based medical care through video conferencing, through telemedicine, up and running over the course of about 3 or 4 years. My day job I love, but gets in the way of some of the fun and creative stuff I get to do with My Healthy Schools and CRHI. And right now I kind of split my time between Bakersfield Clinic, and then I'm there about 3.5 days a week, and then and running this program with my good friend Amanda Martin, who's our executive director. And currently we provide access to acute and chronic medical care, mental health services and mental health services at 10 schools in Mitchell and Yancey County. So access for about 2,600 students, and we have 4 more schools to add in. And we're also providing access for teachers with coughs and colds and high blood pressure.
Yep.
Yeah.
It's a great story and a wonderful evolution. I want to revisit just 1 or 2 parts of it before we go along. I find it really interesting that you're able to bridge the gap between educational services, in a school system, and healthcare services. Also, that education was like your entry point to becoming a doctor.
Yeah. Yeah. The top reasons the kids drop out of high school are mental health issues, substance abuse issues, and pregnancy. So it's often always tied into their health. There's this great model called the biopsychosocial model of health, and so looking at the person as a whole being, that how they feel impacts how they interact with their community and how they're engaged. The high school football player, and I didn't play football, but You know, the star quarterback, if he breaks his leg, and his entire identity through high school has been, I'm the star quarterback, he now doesn't have that role. And since he doesn't have a way to fit in and isn't identified in the same manner, he may withdraw, his grades may slip. Changes in academic performance are often one of the early signs of depression. There's a fella out of Teachers College at Columbia University named Charlie Bosch, B-A-S-C-H, and he has a great book, or a great, not so much a book, but a publication on the health barriers to learning. I can toss that link up in a little bit, I guess. And yeah, Charlie and I've sat on a couple panels together. So that interaction between healthcare and education, I think, is critical, and we miss it so often.
I think, you know, it would be helpful if you could get a little bit more into a description of the demographic of our area,
Yeah.
and then lead into what prompted and why the Center for Rural Health Innovation is so vital in an area like this, or Edgecombe County. So give people a picture of Western North Carolina. A lot of our viewers are urban and suburban in the Northeast Corridor. You know, this is unfamiliar geography to them. So give us a snapshot of that.
So where Mark and I live is Mitchell County, North Carolina. It's located halfway between Asheville and Boone, with the Blue Ridge Parkway on the south and the Appalachian Trail on the north. It's an extremely rural community. Mitchell County has 4 miles of 4-lane road and 11 traffic lights total, and that includes the blinking yellow in Bakersville. Yancey County, right next door to us, and going back, our total population is under 16,000, and Mitchell County is one of the few counties in the nation to lose population in the last census. And in our state, we're currently rated as, out of 100 counties in North Carolina, we're the 59th healthiest. Last year we were rated as the 82nd, but we always find ourselves in that bottom, bottom half or lower. And one of the big reasons is that it's hard to recruit physicians to rural communities. Especially when there aren't enough primary care physicians as it is, we don't do a good job of bringing them in here. Mitchell and Yancey County have been incredibly lucky, and unlike some rural communities in America, we have very few foreign medical grads. So often a medical student from India or the Middle East will come to the U.S. to do a residency program in family medicine, and they want to stay in the U.S., but the only way they can do that is acquire something called a J-1 visa. And a J-1 visa says, well, you'll go practice in an area for an underserved area for 3 years, and then you'll be allowed to live in the U.S. and have go wherever you want. And that really changes the dynamic that patients have with their doctors. So Mitchell County is coming back with sort of basic demographics. Very poor. In March, our unemployment rate was 15%. And it's important to remember that unemployment rates don't count those folks who have given up looking for work, are self-employed and not working full-time, and also don't count the craftspeople in our community. Yancey County is very similar. There are 3 big factories in the 2 counties that employ people. The other big industry is mining, and between the 2 counties, there are 38,000 people. And I don't know a population density. I think it's about 70 people per square mile, but that doesn't sound quite right. I think it's much smaller. So it is tough. And both Mitchell and Yancey County are federally designated as health professions shortage areas, or HPSA areas, meaning that Federally qualified health centers can exist there, which is a federal funding stream for the construction of health centers and the funding of health centers where people don't have good access to care. Their mental health services in North Carolina as a whole are in shambles. In rural areas, it's a lot worse. I'm very fortunate to have a great LCSW, licensed clinical social worker, working on our practice. But there's one other full-time licensed clinical social worker in Mitchell County right now. And then and mental health needs in rural communities are often higher. Other issues, prescription drug abuse is huge and really changes the dynamic and relationships that kids have with their parents, and the rates of teen prescription drug abuse are really high. Does that help, Mark? Is that sort of?
Yeah, that's good. I just wanted to make sure that everybody knew, because part of the story is why this is such a critical project here. So give us an overview of the Center for Rural Health Innovation project, and then we'll get into the telemedicine element of that. Because as I was researching, I was familiar, I was familiar with the telemedicine project to some degree, but the Center for Rural Health Innovation is covering a much broader territory than just that point-to-point care delivery.
Yeah, we're trying to. We are a relatively new nonprofit. We created ourselves, I guess, I don't know, to sort of be the umbrella organization of My Healthy Schools, our telemedicine network. And that out of that has sprung a desire to look at health education in rural communities. And we're building a new building at Mitchell High. Currently, in the fundraising process, that'll be a 7,000 square foot green building. That'll have a classroom space for health profession students, a community space, and also a fully operating clinic where health profession students can come and train. We also have another program called Homegrown Healthcare, which we've launched to build on this idea that rural kids are much more likely to practice in a rural area than somebody growing up in suburban Omaha. So my sons, Eli and Oscar, who are 5 and 7.5 right now, just the fact that they grew up, that they're growing up in Spruce Pine, it makes it more likely that if they become health professionals, they'll come back to a rural community. And some studies cite a correlation coefficient of 0.92. The closer you get to 1, the closer it is that happens every time. But for physicians who grow up in rural communities, about 92% of the time they say they come back and practice here, and that's critical. So we're trying we've created an online environment, and what we do is it's a private social network on Yammer. Providers sign up, students sign up. We're trying to get the middle ground of current undergrads and professional students, so that a student interested in pharmacy can talk to a practicing pharmacist in the community, but also students from rural areas who are currently pursuing pharmacy. And at the same time, stay in contact with their high school classmates who have pursued physical therapy, are interested in becoming a general surgeon, but so both a sort of hierarchical path, but also a lateral connection, and allow conversations and mentoring to occur there, and then followed up with in-person experiences here in our area in shadowing. Yeah.
Just roughly off the top of your head, how many students are involved in that program at the moment?
We honestly launched in March. We are at Mitchell High School, and we've had 42 students who have filled out the original enrollment package, or it's an online survey. Right. And we've got about 20 healthcare providers who are getting enrolled and logging into Yammer to start providing that support.
Right. So that's
Yeah.
a brand new program.
Yeah, it's a brand new program.
Yeah,
Yeah.
but it's great because you're like home growing our own healthcare providers.
That's our goal. We hope to be able to track these folks long term and see if it really makes a difference. And also try to bring in Yancey County next year and then start expanding regionally. Yeah.
Are there any projects like this elsewhere in the state, or how does it fit in nationwide? Is there similar initiatives going on nationwide, or is this kind of a model and you're making it as you go?
There are bits and pieces of stuff that we do going on nationwide. The idea of a pipeline program for rural students is not new to go, but it's almost always exclusively one health profession tied to one academic center. So University of Illinois has a rural family medicine pipeline program. They identify kids early, get them hooked in, follow them through college, some summer experiences, and then have them come to University of Illinois. But this sort of idea about multidisciplinary, trying to make those connections early and follow them through is, this is the first one I really know about, or ours is. And the use of social media to this extent. As far as the combined teaching space and clinical space, we may be breaking some new ground there.
Yeah.
Yeah.
Great.
We hope.
Progressive things happening in our little part of the world, which is really important. And part of what we do on our channel is we seek out people and organizations that are providing real-time, real-life solutions. So in hopes that when we communicate that, people will see that and get the idea and say, oh, we need to talk to these people or something. Like it helps stimulate similar projects. So I really believe our solutions are all going to happen locally to global problems.
Yeah.
Why don't you give us some detail on the telemedicine project?
Okay.
Like an overview of what it is, how it works, and how it's deployed. And then I'm going to play the movie. We have this beautiful 5-minute movie that Dr. Steve in the center did, and I want to play that after he describes telemedicine, because you'll get to see a little bit of it demonstrated and in action. So, rural telemedicine, what is it? How does it work?
So we're doing Skype right now, and it's internet video conferencing. Skype is not what's called HIPAA compliant. I need to take a break. I need to say goodnight to my sons, Eli and Oscar.
Do that. Yeah.
So good night, guys. I will see you in the morning for breakfast. If I don't eat all the honey nut cream cheese tonight. I'm joking, Oscar. All right. So anyway, Skype isn't secure. Somebody could, in theory, if very bored, hack our call tonight, Mark. And in medicine, every time we go to the doctor, we look at this HIPAA program or compliance document saying, I'm not going to go to the grocery store and talk about what you and I talked about. We won't share your medical information with anybody unless you give us permission. And that's really important, especially when you begin to talk about video transmission. So the backbone of our network is video conferencing through a secure a bridge, and we have that on the school district network in Mitchell County. And the great thing about the bridge is that it allows multiple people to come into a conversation simultaneously, and it's all very secure. 128-bit encryption, which is the standard needed for healthcare data exchange. And then, so if you take that video conferencing technology, which is really desktop video conferencing, and you hook in a stethoscope that plays through your computer through a separate application. The stethoscope I use looks exactly like the one that I use in the office, except that it's got Bluetooth in there. And so if one of our nurses is seeing a patient at a school, they use this stethoscope and it transmits back to me at my laptop. and I actually can record that if I want to. Then we use an otoscope, which is the ear looker thing, and it looks exactly like the one that I use in the office. We had a fairly fancy and expensive one that wasn't as good as this one, and it has a cord coming out for the little video camera in there. And again, we run that through it runs into a web browser on our computers, on our telemedicine cart, which you'll see in the video, and we can look at ears. But if you've ever taken your kid or gone to the doctor and had somebody look in your ears or seen a kid getting their ears looked in, you know that the child squirms just a little bit. It's tough, especially on a 5-year-old with an ear infection, to get a good view. The nice thing about this is I can freeze that image, and it's on my screen in HD. I can blow this thing up and see the ear so much better and clearer. And I can also include that in the medical record. The next part is that we've got a general exam camera, so we can look at rashes and sprains and tongues and whatever else needs to be checked out. The key is having a skilled person at the other end, so at what's called the originating site, where the patient is, who is able to use the equipment and has some basic medical knowledge, so they can, put the stethoscope where it needs to be, feel for lymph nodes, which is something I can't do through the camera. And that's what we do. So it's a regular doctor's visit. I do, a mix of physical exam stuff and counseling stuff, especially around the adolescents that I see. And I do a fair amount of mental health work, sort of child and adolescent psychiatry. Mm-hmm. Yeah.
And so this is really important because we go back again to the demographic and the accessibility. I mean, physical accessibility. Some of these schools are in pretty remote areas. The roads are bad. In the wintertime especially, it's treacherous. And so if the school bus is out, then you can get them to one place.
Yeah.
And then at least you have a resource and you can do triage and look at things and develop, okay, what comes next.
I mean, we can prescribe medications and avoid a drive into town to be seen. Especially a lot of parents are working off the mountain in both Mitchell and Yancey County. There's a big Baxter plant literally down the mountain from where we are, probably about 1,000 feet lower, elevation-wise. Yeah. And for a parent to need to leave work, drive back up the mountain, pick up their kid at school, drive the kid to my office or any doctor's office, hoping that at 4 o'clock in the afternoon there's a slot available, could be a real hassle. And then to find out, well, it was a virus. I'm glad it's a virus. I'm glad the kid doesn't need antibiotics, but we could provide those same services at their school and decrease the burden on the family. And then mom and dad have more PTO for their vacation as opposed to using it to take the kid to the doctor.
Right. I think this is one of the things that a lot of people don't realize, that here, depending on where you live, like if you live at the north end of the county, a round-trip doctor's visit is a good half day, if not more, if everything goes right. So yeah. It's quite a production. So that was the overview on telemedicine. So I'm going to queue up this video and we're going to play it, and it's going to be about 5 minutes long. So Steve and I will just sit quietly while the video plays, and you guys can get a look at it, and you'll get a better idea of A, where we live, and B, how this system works. So hang on, I'm going to mash some buttons and cross my fingers. And Steve, we'll just try to sit here. I'm going to leave our mics on, so, remember you have a hot mic, and, we'll try not to make
mine, yeah.
We'll try not to make inappropriate comments. All right, so here we go, Steve's movie.
In our community, accessing health care is a major challenge for many people due to barriers of geography, windy mountain roads, and also a lack of healthcare providers. By providing healthcare services to kids at schools, parents don't need to feel pulled between working to provide for their families and taking their kid to the doctor for a cold, an earache, or a strange rash.
The parent signs permission ahead of time at the beginning of the school year in the permission packet. No child can be seen without parental consent. I will call the parent and say, you know, we're going to see your child today. Would you like to come in and be a part of this and talk to the nurse practitioner?
Nurse practitioners are able to diagnose and treat the majority of illnesses that a family physician or a pediatrician would see. My Healthy Schools operates just like a regular doctor's office as far as making an appointment and billing for services. A parent can call and ask us to see Johnny for an earache or a sports physical. Johnny can come down and see us and we'll bill his insurance. For kids who do not have health insurance, we will see those kids without any charge to the family.
I feel the telemedicine program supports both the students and myself in two major ways. The first is the students who are my patients are able to be seen, triaged, and have their problems addressed in the school setting, allowing that child to stay in school if at all possible. For me personally, patients are no longer banging down the door at 4 o'clock when they've gotten out of school, trying to get those last-minute walk-in appointments, and I'm not feeling as bombarded with strep throat checks, coughs, all of those simple things that could easily be done in the school setting and are being done in the school setting thanks to telemedicine.
Remember that whatever I can see on the screen, so can Amanda, and you can too, okay?
Both the nurse practitioner and Yvonne were wonderful. The quality of care was phenomenal. Liam trusted Yvonne, and I felt very confident in their decisions with what was going on. I was also thankful that I didn't have to take him to the doctor's office where the flu was going around or, any kind of illnesses that he would be susceptible to.
It's a very useful way to, again, prevent a kid from missing a day of school for an easy, quick 15-minute follow-up, such as an asthma exacerbation, sprained ankle, strep throat. All of those are good conditions which may require somebody to lay eyes on them another couple days. And again, it doesn't have to be me. I don't feel threatened by telemedicine seeing my patients because I know in the end I'm still their medical home.
We are not here to replace 10 or 15 years of relationships. One of the ways that we can do this is by taking pictures of infected ears or of a rash and sending them electronically to the primary care physician, along with a copy of the encounter note. School-based health centers have been demonstrated to improve attendance, increase graduation rates of at-risk students, result in improved care of chronic illnesses like asthma and diabetes, and also reduce students' dependence on the emergency room for non-emergent healthcare issues. 75% of the visits to the emergency room could have been better served at a regular doctor's office or through our school-based telemedicine network.
Whether they don't have insurance or their parents, they work at odd hours, they can't get them to the doctor, telemedicine has worked great at decreasing the number of those children going to the emergency room.
We know that attendance is a major contributing factor into success of students. So we're fortunate that our students can visit with a doctor on a daily basis if they need to here at our school.
In addition, school-based health center offers behavioral health services, allowing kids to talk to a counselor about their weight, being bullied in school, or the death of a grandparent. School-based health centers are a way to provide comprehensive care focused on children and adolescents, where kids spend the majority of their days. We believe that having healthier kids results in a healthier community and also better academic outcomes.
Okay, so there we go. Come back here. So we're back on screen there, Steve. So thank you for letting us share that film. It was a really good introduction, and I'm watching it, and you know, we talked off channel before we came on about the week I'm having at work. So my question is, like, having had my hands on a little bit of that stuff, but the tech is kind of whiz bang. So does it serve well? I mean, is your uptime really good?
We run into a few glitches along the way. One of the carts at a high school where we had about 500 students had a technical problem when it came from the factory, and it took them about 3 or 4 months to figure it out. That was very frustrating for us. But now we're up at every school, and it's running very smoothly. One of the great benefits is that we are able to use the school district's fiber optic network. So at the real small schools, the bandwidth is 100 megabytes per second. And then in Mitchell County, it's recently been bumped up to 250 megabytes per second. So yeah, I can see the chat feed on my screen as well. And yeah, I completely agree that Yvonne Harden, our awesome school nurse, looks like Sarah Palin. We would not be able to do this without the school nurses. She is our one of our biggest advocates, and has helped convince a couple other school nurses that we're actually bringing another tool to help them, and that we're not threatening their jobs.
Right.
Yeah.
Which that's a good segue for a question I had for later. But what's the response of the community that we're serving? And I did want to make it clear, at the moment the population we're serving is limited to the school kids.
Let's see. Let me talk through that one, because it's not just school kids. All right. We are, let's see, we're serving K through 12 kids at 9 schools, and we also see the faculty members at those schools as well.
Okay.
We then also are out at Mainland Community College, where there's an early high school program. So kids who are doing a 5-year, 9th grade through an associate's degree program. And so we have a cart there for them that we're also using to see community college students. One of the challenges a lot of community college students face in our area, excuse me, is that they have lost a job at, like when Ethan Allen closed, where they had good benefits, good health care, now have no health insurance. So we have a sliding scale that covers those folks through a state grant, and are able to see them as well. But you have to basically be either a faculty member at a school or enrolled at a school right now.
Right. Somehow connected to one of the school system.
Yeah.
Yeah. Okay. And I have a question later on to expand on that, but I was wondering what the community response to it has been. You touched on the school nurses. You know, so what has been the patient response? How many? You know, what have been the challenges to overcome as you roll this out?
Well, one of the challenges has been there isn't a growth curve for school-based telemedicine, so we don't really know what to expect. Our first year in operation, the 2011-2012 school year, we were in 3 schools and didn't see a whole lot of kids, and one of the reasons was there wasn't a bad flu season. We were also only available part of the time. The recruiting providers has been a challenge. Up until January, we were not available full time because we couldn't find a nurse practitioner. And so we have found a retired pediatric nurse practitioner who, coincidentally, I worked with when I was in Rochester, New York. She ran a teen health center there, and we are now. She's working with us. She lives in Weaverville, and so connects from her kitchen to the kids. And so the growth has been much better since we're available full time. or when schools open. But it is a word of mouth thing. 18 months ago, when we sort of hired our first full-time employee in Amanda Martin and got somebody on to help with publicity and stuff, we weren't really a name that people knew. However, this year, when you mention My Healthy Schools, people know what you're talking about. My colleagues who work with me don't have to explain who it is they work for anymore. And it's an interesting, it's a great sign of growth. So we're hoping that as kids sort of grow up with this in their school, they're going to become more and more comfortable using it, and their parents will become more comfortable using it.
And there's a question that's kind of pertinent to this part of the discussion about the concern for liability issues, because it's not necessarily person to person for diagnosis and stuff, I guess. So how is that taken into consideration, and is there any additional concern beyond what would be normally considered?
Yeah, I think that we do need to be more aware of our limitations as providers. What is it that we really can diagnose and provide in this manner? I can do a great job with ear infections. I can do a great job with strep throat. I also can differentiate if Johnny's belly pain is acute appendicitis, or if it's the belly ache he gets every Tuesday morning before his before his spelling test. So, but when it comes to sort of the need to really lay hands on a person, that we can't do that, and it is a limit. And you need to be able to say, we're going to send this on to your primary care physician, or arrange for you to be seen in real life, face to face. Now, interestingly, there are studies out there, of course, because medicine loves to do studies, showing that diagnostic accuracy for ear infections is equal, whether you do it via telemedicine. The two docs see a patient on telemedicine. They agree with the same amount on the diagnosis, the same percent of the time as two physicians who see the same patient in the same, in the room sequentially. So that's really something in our favor. And there's some things like eye diseases that we don't do right now. We don't do any retinal work, but screening for diabetic retinopathy and early signs of that is actually done better using telehealth technology, getting an image that is much larger than me trying to look into a patient's eye, but being able to get a high-res image and blow it up. Yeah.
I think you hit it on the head earlier when you said that the telemedicine is another tool. It's not a replacement for anything. It's an additional tool and resource to help provide a broader scope of care.
Yeah, it is. And school-based health centers in general, which is what we're trying to be and provide, reduce unnecessary emergency department visits for kids. In kids with asthma have been shown to reduce hospitalizations, reduce overall healthcare expenditures, and increase the amount of both screening for high-risk behaviors, but also sort of the well child checks that occur, because it's the convenience factor. And school-based health centers are also shown to increase graduation rates. Using a school-based health center increases graduation rates in high-risk students. So being in the school makes a difference.
Yeah. So what is the long-range plan for the telemedicine element? Because I'm sitting here, nerding out, and this is, in part of researching this, I came across an article in the New Yorker from last year that was talking about, I guess, to oversimplify, similar technology being used as command and control for multiple ICU units.
Yeah.
Very much the same thing, and it was the same discussion as like the people in the ICU units were like, a little bit hesitant because like who's trying to control and it's hands-on. But the argument was this was an additional resource. And so in my mind I say, wow, you know, we got these things in the schools. If you could expand that and you had, you know, staffing the healthcare professionals to be the ones on the scene, then it opens up a whole new arena for community healthcare for everybody, for me, you know, for everybody, not just people connected to a school.
So this is sort of a great conversation, and I think the first part is to talk about the really high-tech stuff. Here in Spruce Pine, we have a robot in our emergency room that a neurologist at Mission Hospital in Asheville can drive into a room and see a stroke patient without the assistance of anybody else through video conferencing. Do we really need the robot? Probably not, but it does free up other people in an emergency situation. And that is doing what's called telestroke care, telerobotics. That is great because it's shown in telestroke to increase the number of people who are getting clot-busting drugs, or TPA, because it reduces the amount of time before you can see the neurologist, and it has great outcomes. So that kind of stuff, along with the ICU monitoring, is amazing. You're bringing specialists to a rural community, to an underserved community that wouldn't be there otherwise. So the inpatient stuff is great, as long as it is up and running and works. But that's the fear with any of this,
right,
that our connection will drop. But thinking about the sort of specialty care stuff that is provided in big cities that we don't have access to here in Spruce Pine. I have a 14-year-old patient who has cystic fibrosis. She attends a school with a telemedicine unit, and she still has to drive to Chapel Hill to be seen by her pulmonologist every couple months.
Which is a 4-hour one-way trip.
Yeah, thanks. Sorry, 4-hour one-way trip for a half-hour, 45-minute appointment, and it is not. It's not our fault. I mean, the technology sits there in her school, and I've talked to the pulmonologist, and I know the telehealth people at Chapel Hill pretty well. They're not ready to make that jump. Right now, honestly, if a kid saw a specialist at Johns Hopkins, they could be seen in their school, or at Seattle Children's Hospital. The technology's there. It's a systems issue in larger organizations. My fear, as we sort of push this out, telemedicine technology right now is expensive. To put a cart in a school, our last set, they were installed, taxes, everything, it was $24,000 per cart. Of course, that price is coming down, but it's still, pricey. So for a small clinic to afford a telemedicine cart, it's a big investment. But a big hospital system has that money. So they could easily toss a cart out at my clinic in Bakersville and say, well, this is here for you to use to see our specialists. And so you can see everybody who's at the big city hospital through this cart. But when Mrs. Jones had her heart surgery done at the university hospital, oh no, you can't use that technology. So are we going to be in a position where you've got two carts sitting right next to each other, one owned by the university hospital, one owned by the big city hospital, that are competing, and so it's a duplication of technology. I really hope we don't reach that point, but that's something that not a lot of people are talking about. How the small communities can create basically a site that brings in everybody.
Right.
As we talked about earlier, this new building at the high school, and one of the things we want to do is have that be a telemedicine originating site to go anywhere you need to go, whether it be East Tennessee or Duke or Emory. you can see your specialist for follow-up there. And there's some tremendous telemedicine networks out there. North Carolina is probably 10 years behind Virginia as far as expansion and use of telemedicine. And Virginia, New Mexico, California, and Arkansas are probably the national leaders in statewide telemedicine networks.
Well, it also, assuming all those other issues could be worked out, one of the challenges we have in a rural area is, internet access and bandwidth, because the whole thing is dependent on that.
Right.
And in our area, we have very poor internet services for the general public. So it limits the places that these units could be placed at and used effectively.
It does right now. It is going to change in our community, actually. We just received one of the Broadband Technology Opportunity Program grants, or BTOP grants, and in Mitchell and Yancey counties, probably by January or February of 2014, every home in the county, in both counties, will have access to 100 megabyte per second fiber optic internet through Country Cablevision. And Dean Russell is the guy who's heading that project up, and he's on our board. They've run into some regulatory issues that are now passed, but it's definitely coming. And one of the things our group is trying to do is be prepared to take advantage of this.
Right.
Oh man, hang on.
Did we lose you?
Pizza night, get a large for just $12.99.
Oh, you got a commercial.
Hey, sorry, Mark. I pulled the website back up, and then all of a sudden, the Pizza Hut commercial came on, thanks to live stream.
Yeah.
So I'm going to try to get that off the browser now. And mute my... There we go. I think everything's better.
Yeah.
Yeah, I love it when I'm the technology guy and I screw up the technology.
Oh, it happens all the time. A couple of weeks ago, I had this super good interview. We had 5 people from all over the United States. It was a huge deal, and I forgot to plug in my adapter. So I got the battery warning So yeah, it happens. So we're back on the 100 meg internet service, and so you guys are going to be prepared for when it shows up. You'll be able to avail yourself of it instead of taking a year to catch up to it.
Well, we hope so. We're trying to work with the home health folks out of the health department to put together an idea about how to do advanced home monitoring. How to provide maybe dementia patients with support at home, both for the patient and for the caregiver. Already there are Bluetooth-enabled scales that patients can use, and they weigh themselves if they have something like congestive heart failure. They weigh themselves on a daily basis. It's sent automatically to the cloud, where it goes through an algorithm, and the information's kicked out. If they gain too much weight or lose too much weight, you can have a device at home saying, well, now increase your dose of this medicine.
Yep. So, I think it's great that we're looking ahead and availing ourselves of the I can't wait for 100 meg. If it happens, I'll be happy.
I will be very happy. I'm going to work from home. Yeah.
Yep. So, the million-dollar question, literally, is how is this all being funded currently, and what's on the table to continue the project?
All right. So, funding.
And if you could tip your camera a little bit, you're really low. There you go. Perfect.
All right.
Yeah.
So the funding stream, we have been very fortunate in funding, and I think one of the reasons is that we took our time to do our homework before applying for big grants. So we started out So two streams of funding. First, we'll talk about equipment funding because that's the big dollar item. And we turned a local $40,000 grant from a local foundation into $120,000 by matching it with the Appalachian Regional Commission. We were then able to match that money, $1 of ours for $2 of the federal United States Department of Agriculture Rural Utility Service Distance Learning and Telemedicine grants, which are called RUS grants and are sort of the biggest grants around for telemedicine expansion. So we had $400,000, which really let us put our initial network in place and buy all the carts that we have in place now. We then have 2 additional federal grants towards equipment for our next 4 carts. So the equipment has all been grant funded up to this point. But the sustainability and the operation stuff is key. Initially, we've had a couple of different funding streams. The Kate B. Reynolds Charitable Trust and the Blue Cross Blue Shield Foundation in North Carolina provided us with startup money and grant funding. We now have 2 streams of state funding to see the safety net patients through school-based health centers, and then also the money to do the work out at Malin with the sliding scale fee. But we're billing insurance. I mean, I think that's how we're going to make this survive. We're getting reimbursed by Medicaid, Blue Cross Blue Shield, and either United, and I think it's United Healthcare. Those are the 3 we've been reimbursed by so far. And when we did some projections and some cost modeling early on, if there were 1,000 kids who could be part of our network, enrolled in the schools, and let's say that 75% of their parents gave them permission to actually use the program, and about 50% of them actually did, we'd need to see each kid 2 times during the course of the year to break even, to pay the provider, and that's based on either Medicaid or a private insurance, and also knowing that we'll have about a 10% uninsured rate, and it's really important to us to see the uninsured. So sustainability, I think, is coming. We've got 2 years left on the state grants, so I think we're going to be okay. We also are looking at other income streams. We do some consulting right now about how to replicate this kind of thing nationally. And one of the interesting things is that there are unknown the real number of school-based telemedicine programs out there, but the vast majority have been established by large academic medical centers, hospital systems, or federally qualified health centers. And if you really want this to be replicable in rural Alaska or the Mississippi Delta, you need to be free from those large financial pockets, I feel. And so because of that, we were selected as part of the Telehealth Resource Centers, a federally funded group of 13 programs that helps to encourage use of telemedicine, to consult on this idea. So we, I was in Little Rock, Arkansas 2 weeks ago talking about this. Monday, I'm talking to folks in rural Mississippi 2 different times about how to get a school-based telemedicine program up and running. There's a woman in northern Montana, in Coeur d'Alene, Idaho, who we talk with. So we're trying to, spread the gospel, share what we've learned, make that phase of trying to get this thing up and running, not be a 4-year process of nights and weekends, but instead be a 1 year, here's the toolkit, get your community on board, let's go kind of program.
Yep, I love it. And some of those communities I've been into, and they desperately need it, and good for you.
Mm-hmm.
I think it's a good point to make that essentially this will work if it remains independent. And one of the questions I had that you already addressed was the connection to a major hospital system. And I hadn't thought about that, you know, competing carts and all that, but that is a legitimate concern. I mean, you can see, you know, the competition for the healthcare dollar. So anything we can do to avoid that will serve the clients much better. So, so why don't we wrap with give us a view of what's in store next year for the Center for Rural Health Innovation.
Well, with My Healthy Schools, we'll be in 14 schools and providing access to 3,500 students probably. They, on a daily basis, they'll be able to see one of our providers if they need to. And looking to expand into some adjacent counties, possibly McDowell, possibly Avery or Madison. Then, as far as our big project at the high school, we're excited. You know, we've got about $800,000 in the bank to build that building, and you know, have another grant to write, a couple other organizations to talk to. But that building, we should break ground on that, we hope, in the fall, and then be up and running as soon as we can, and get kids in that new science classroom. Our science classroom, or not, I'm sorry, health sciences classrooms up until a year ago were in a now condemned double-wide trailer at the high school. So we are really trying to replace that with a state-of-the-art building.
Right, right.
And then some home-based stuff. We really want to get involved with that. It's about manpower, and you know, this is not my day job. It's nights and weekends, and we've got one full-time employee right now, Amanda. And unfortunately, she spends too much of her time troubleshooting the network and training. So hopefully in our second year of being up and running full speed, she'll have more time to devote to the non-technical side and into the creative stuff.
Right.
Yeah.
Well, it's exciting time. You know, the combination of the educational elements with the healthcare service delivery element is so badly needed, and it's so encouraging and inspiring to hear about this. You know, I've watched it, and to be able to hear the details of it, it's even better, you know, than it was in my head. So congratulations on good work, and I know you pour your heart and soul into it, and thank you for doing that, and for also modeling it and being willing to give the idea and the expertise away to others out there that can use it, because, you know, it's a great social action exercise.
Yeah, I think it is. I think that access to healthcare is a major social justice issue.
Right.
And so we need to use it to help people reach their full potential.
Right.
Yeah, thanks for having me, Mark. This has been great.
I appreciate it, and we'll let you go now so you can get home to Jen and the boys, and thank you so much for being on. This has been Dr. Steve North from the Center for Rural Health Innovation here in our little part of Western North Carolina, where we're working on solutions. So thank you, Steve. Have a good evening.
Thanks, Mark. You too. Have a great night. Thanks, everybody, for watching.